Hello, I am Dr. Carey. I'm a pediatrician in Ventura, California, and this is Dr. Carey's Baby Care. Today we have Esteban Bonfante, who is a pediatric gastroenterologist, and we are talking about gastroesophageal reflux. Welcome.
Thank you very much for inviting me.
Boy, if ever there was a topic that comes up a lot in pediatric practice, it is reflux. Babies are spitting up constantly. And usually I tell parents to get a stack of cloth diapers because they make wonderful wipe rags because it's all over the place. And it's also concerning for parents because what seems like a lot can be very little, but if you actually poured 2 ounces of formula out, you'd realize that there's a difference between spitting up a little bit and spitting up a lot. So with that, why don't we start by getting some definitions out of the way and distinguish what gastroesophageal reflux is versus gastroesophageal reflux disease or GERD?
Well, gastroesophageal reflux is normal. It's a backing up of gastric contents into the esophagus by intermittent relaxation of the muscle that is the lower esophageal sphincter. It is normal and it's physiologic unless it's complicated. When there's a complication of gastroesophageal reflux, then we call it gastroesophageal reflux disease. Mm-hmm. And that's a separate concerning condition. But just reflux by itself is physiologic, is normal in infants, children, and adults.
And when you have a baby, when does it become concerning? When should a parent come asking the pediatrician, is this normal?
Most of the times they are concerned by just some spitting up because they think that, well, we think that most of the formula it's difficult to estimate how much they are speeding up. However, it is only concerning when there are the complications that we are going to mention. And some of them are failure to thrive. That means that there's caloric deprivation, more formula is coming out than the formula that they are keeping. Or when there is uncomfortable for the baby, or the baby may have fussiness. Also, they may have esophagitis, and the inflammation in the esophagus is painful, and they may refuse to feed because of this inflammation.
So when you have a newborn, during the first 5-6 days of life, they're going to lose about 7-8% of their weight, oftentimes. By 2 weeks, they're back at birth weight. And then ideally, they should be gaining about half a pound a week until about 4 months of age. At what point of life does reflux become evident? At what point will you see failure to thrive or a child who isn't gaining weight properly?
Well, it's very important to have frequent office visits to check the weight. And it is concerning when they are not following the growth curves, mm-hmm. or the amount of weight that they're supposed to be gaining. After regaining the weight, they should be gaining 20 grams per day. If they are not in association with reflux, then that's a concern.
Mm-hmm. And is it, though, at 1 month, at 2 months, that reflux tends to start becoming evident?
Most commonly 2 months to 4 months.
2 months to 4 months.
That's the age when,
mm-hmm.
when it is most evident.
Mm-hmm. And one can have a lot of difficulty with discomfort also, so they might be a little more fussy than more than just spitting up.
Yes, there's some babies in the extreme or in the most severe type of reflux. They may develop a syndrome that is called Sandy-First syndrome, mm-hmm. and they may arch back. They may be fussy, and they may move their head from side to side, and they may be screaming. Yeah.
These can be confused with seizures sometimes, can't they?
Can they? And they need to be ruled out, actually.
Mm-hmm.
Yeah.
And So is it you who often who suggests the neurologist to rule that out, or do you do that on your own as a specialist in gastroenterology?
Well, what I do is I take care of the gastrointestinal issues, and I try to take care of the reflux. Mm-hmm. If these symptoms go away, then it is unlikely that they were associated with seizures.
So assuming that we have just basic reflux over here, what tests, if any, are you going to do to try to figure this out?
Well, the first thing that I'll do is an upper GI series. In that case, rule out anatomical abnormalities that may be leading to reflux.
What is an upper GI series?
An upper GI series is given a baby contrast with the bottle, mm-hmm. and the contrast will show the lining of the esophagus, the stomach, and the small intestine.
So they're swallowing some kind of formula that has something in it that shows up on the X-ray, and then they take a look to see if the structures inside are normal.
That's correct.
Now, that's not going to pick up every kind of abnormality, is it?
Not every kind, but if there's obstruction, the contrast won't pass as it should be.
Okay. So we'll see obstruction very well. And sometimes the radiologist will say, oh, there's some evidence of reflux from the study. How accurate is that?
It's not accurate because, as I was mentioning, we all have some physiologic reflux, and the X-rays is just one time, mm-hmm. one picture, and one moment. Mm-hmm. So if at that time the baby had one of those episodes of physiologic reflux, it will show.
Okay.
And so it's not good to make the diagnosis. In another hand, is not also a good test to rule out reflux, because at that moment, the baby might have not have any reflux at all.
So you have a baby who seems to be spitting up excessively. They are uncomfortable, and you've done an upper GI. Everything structurally looks okay. What's next? What are you going to do?
The best test is a 24-hour pH probe study with impedance. Mm-hmm. That's the gold standard for reflux. And what the pH probe detects is a small rubber-like catheter with sensors, and it's placed through the nose and left in the middle of the esophagus. So mm-hmm. every time that there is reflux from the stomach into the esophagus, is detected by that pH probe. At the other end, there's a recorder computer
right.
that identifies every episode of reflux. Also, it's a very good test to associate symptoms with reflux, because we can mark an event in the computer. So if the baby is having coughing, choking, or crying, and there's an association in that moment with reflux, then we can tell for sure the baby's crying because of the reflux and not because something else.
Now, are you ever going to treat babies without actually doing a pH probe, though?
Yes, we'll do the initial treatment, because many babies just improve with the thickening of the formula with mm-hmm. rice cereal. This makes the formula more dense, and it is more likely to stay in the stomach and not coming up. Another intervention is trying a hydrolyzed formula, because many babies with cow milk protein allergy may have reflux as a complication. Mm-hmm. So a hydrolyzed formula will take care of that condition.
Okay. Medications, when do they come into play?
Medications, once we make the diagnosis of reflux. Mm-hmm. In infants, in generally, medications are not indicated, or there are no studies that have shown any benefit of anti-secretory treatment or anti-acid treatment mm-hmm. in babies.
But how about the ones in pain? How about the ones who are really in discomfort? And it doesn't happen very often, but I can think of, I had one baby years ago. I knew when they walked into that waiting room. I mean, I could hear them screaming from the waiting room, and this was really a scream from pain from reflux. In the moment that they were treated, all of that disappeared.
Well, in those babies, once we make the diagnosis, then definitely we need to treat them. Mm-hmm. And we use anti-acid medicine. Mm-hmm. We use H2 blockers. This decreases the amount of acid production. So they may continue having reflux, but the reflux is non-acidic. And because it's non-acidic, it doesn't irritate the esophagus.
With those babies who have it that severe, are there long-term concerns for them?
They may have erosions in the esophagus if it is not treated, but if it is treated, most babies outgrow reflux by 1 year of age.
By 1 year of age. What percentage of babies outgrow them by a year?
Over 90%.
Really? There's still a small subset, though, who will continue, right?
They will continue. Most of them will outgrow it at 18 months of age.
Okay.
Those who do not outgrow it by 2 years of age, they are unlikely and they may need long-term treatment.
Are those typically healthy children, or are these children who often have special needs or some other underlying condition?
Persistent reflux is more common in children with special needs. Yes. Patients who have anatomical distortion, the scoliosis, or neurological problems.
And what other conditions can mimic reflux? What can someone see that in a spitty baby that they should be concerned about?
Well, happy spitters are the most common thing that we could see with reflux, but symptomatology...
I'm sorry, what was that?
Oh, happy spitters, those are the 50% of babies who spit up. Actually, they don't have any problems. They're healthy babies.
Happy spitters.
That's how we call it, happy spitters.
Love it, happy spitters.
But babies may present with coughing, choking, if that's in association with reflux. But not all babies who cough or choke is because of reflux. It may be saliva that they may have a problem swallowing too, especially those with neurological conditions.
My daughter was definitely a happy spitter. I would pick her up. I would never face her towards me because it was all over my shirt the moment I picked her up. I mean, it got to the point where every time I picked her up, it would be away because I knew something was going to come out constantly. And I certainly see a lot of babies at our office who I would classify as happy spitters also. Any other thoughts about reflux that parents should know about? And we've talked about how long it goes, about when it should resolve. Are there any other associations that they should be concerned about, or have we covered most of them?
Well, as long as the baby, I think the take-home message is that as long as the baby is thriving, baby is not uncomfortable, there is no other problems with the airway, choking or coughing, and baby is gaining weight properly, there's no concern.
Got it. And I think that's really, Esteban, really comes to the heart of it, which is you want a child who's gaining weight well and doing really well. Dr. Bonfante, thank you very much for coming. It was a really nice conversation about reflux, which is really a common question and concern for parents. I am Dr. Carey. I hope that you come and visit us at drcareys.com, where we have a newsletter with a lot of information and tips and a lot of interesting information. Again, I am Dr. Carey, and at Dr. Carey's, we teach baby care.
Breathe in, breathe out. Breathe in, breathe out. Okay, let me see your ears.